going to go ahead and get started. So, Dr. Thala, thank you for joining. And since it's essentially me and you, feel free to jump in anytime with questions, okay?
Sure.
I'm going to go ahead and go through the overview of MCT2D and specifically the nephrology practice participation. And by introduction, my name is Mike Hung. I am a nephrologist at the University of Michigan, and I am the program director for the nephrology component of MCT2D.
Okay.
This is the leadership. It's myself and two of my colleagues here at University of Michigan, Dr. Rajiv Saran and Dr. Julie Wright. So we help run the steering committee for, or the coordinating center for the MCT2D, the nephrology component. And so today we're going to go over, a brief introduction as to what is a CQI, what is MCT2D specifically, and then of course, what does this mean for the nephrologists who participate, and what are the requirements to participate, as well as what do you get out of this?
Okay.
So starting with just what is a CQI? CQI stands for Collaborative Quality Initiative. And these are statewide quality improvement initiatives that are developed and executed by physicians and hospital partners. So I think that's really important to note right off, that this is not handed down by administrators alone or by Blue Cross. It is funded and supported by Blue Cross, Blue Shield of Michigan, and Blue Care Network. But these are initiatives that are developed by practicing physicians like myself in partnership with the other physicians. CQIs utilize comprehensive clinical registries to identify patients at risk, identify their risk factors, understand the processes of care, and to examine outcomes of care. And they can address a variety of areas, including those where best practices are not known or have not been widely implemented, or care is rapidly evolving. And we'll, of course, talk about what that means in nephrology specifically. And then the physicians, hospitals, and health systems share data and collaborate in order to improve the overall standards of care in Michigan by focusing on a variety of different types of quality improvement, which can include error reduction, prevention of complications, and of course, improvement of patient outcomes. So how CQIs function, basically, we have our usual practice and we're trying to move things in a positive direction. Important to do that is to get good data as to what's going on. We want to incentivize the participants, make it easy for you to be involved, and also very importantly, provide change management support. So this is very much not saying, go do this. This is very much saying, how can we help you to improve in various areas? And one other thing we would like to point out is that CQIs are meant to be all patient, all payer initiatives, meaning that even though Blue Cross is the sponsor for this and the incentives come through payments on Blue Cross patients, this is not meant to just improve care for those patients that have Blue Cross that fall into that area. This is really meant for every patient in your practice and every patient across the state of Michigan. So we drive a change in culture through a variety of collaborations in different ways. Again, this is the things that we focus on are developed by providers. Okay, so you definitely, as a member of the collaborative, would have input into what are the most important things we should be working on. We use the data from the practices to try to improve everyone's performance. So this is, again, focusing on the word collaborate in CQI, and not, this is not a competitive thing. Everybody can benefit from this. And of course, part of that is peer and coaching support to help foster a positive learning environment for everybody. And then again, using patient data, feedback from patients as well. We have a patient advisory board to make sure that everything we're doing is aligned with what matters to patients. There have been a variety of CQIs throughout the state of Michigan. This is the active list of CQI programs. They've been in existence. Some of these have been in existence as far back as 20 years. And you can see that a lot of them early on of the hospital of the CQIs were procedural or hospital-based CQIs, such as around anesthesia or different surgeries like orthopedics or bariatric, radiation oncology. It's in recent years that this has shifted to include more practice-based CQIs focusing on chronic conditions. And MCT2D, or the Michigan Collaborative for Type 2 Diabetes, was one of the first of those new models looking at chronic disease management as opposed to acute episodes of care. These are examples from other CQI programs that have been successful. For example, the bariatric surgery program focused on hospital readmissions after bariatric surgery, which was a very significant problem. And with their quality improvement projects, working with the collaborating hospital groups and practices, they were able to show a significant reduction in readmissions and an estimated 778 patients not having to be readmitted. Similarly, but differently, you know, our orthopedic CQI focused on blood transfusions and minimizing those after knee and hip replacement, and was estimated to avoid tens of thousands of transfusions as a result of the quality improvement programs. And so there's just other examples here. And I'll be able to show in a little bit what we've started to do in nephrology as well. So we like to think of CQIs as a win for everybody, a win-win-win. They're a win for patients, obviously, because of the focus on improving quality of care. They're a win for us as providers because we obviously always want to do the best thing for our patients. And so there's that opportunity to improve. And also, as we'll talk about later, we get incentivized to do better. And then they're a winner for the payers, in this case, Blue Cross Blue Shield, because overall, these better outcomes tend to lead to reduced costs, improve patient care, improve overall value, and they strengthen the relationship between the physician, insurers, and the patients as well. So now talking specifically about MCT2D, the Michigan Collaborative for Type 2 Diabetes. As you probably, I'm sure you know, obviously, diabetes is a huge problem nationwide and certainly in Michigan as well. About 52,000 new diagnoses of diabetes in Michigan each year, and about 10% overall in the population, plus another significant percentage of patients that have undiagnosed diabetes. So basically over a million, basically 1.1 million patients in Michigan with diabetes. So obviously a very big issue in Michigan. We also know that there's a lot of disparities in care and outcomes in patients with diabetes, significantly higher rates of diabetes among Black patients and Hispanic patients compared to white patients, and including 2 times higher among those with a disability as well. So one of the things that has been really a great progress in the last few years has been shifting from, you know, what I was taught as a fellow was basically that, you know, diabetes is genetic. It's probably can't be prevented. You can only try to slow things down and delay complications, maybe prevent some complications. But I think that, you know, starting in especially the last 10 years and probably even before that, we've seen now that the new school thought is that, you know, diabetes actually can be prevented, especially working through obesity. And obviously we have much better tools now to help manage obesity, and also seeing with some of the newer treatments that the complications from diabetes are not invariably reached, that in many patients we can prevent complications and even reverse the damage of type 2 diabetes into remission. So again, preaching to the choir, I'm sure you know all about the connection between diabetes and chronic kidney disease, as about nearly half of patients with type 2 diabetes will have some evidence of chronic kidney disease, although many of these patients are unaware of that. And then there still are significant gaps in care. So for example, patients with diabetes and chronic kidney disease where ACE inhibitors or angiotensin receptor blockers are recommended, still 1 in 3 don't receive these therapies. And so again, the problem is that there are many patients with diabetes who aren't aware of their kidney condition, have no idea, or in large part because it's symptomatic. And some of those can be at early stage, and yet those are the earliest stages at which probably we can have the most significant benefit. So what we're focused on in this collaborative is to raise awareness of chronic kidney disease among patients with diabetes, and to overall improve the outcomes in those patients by supporting providers with evidence basis for the best practices, and empowering providers with the appropriate tools to optimize CKD education and CKD management with patients. The structure of MCT2D, as I mentioned earlier, there is a patient advisory that's of course central to what we do. There are currently 29 physician organizations in Michigan that are involved, and over 400 physician practices and 1,200 plus physicians. Overall, this includes primary care, as well as nephrology and endocrinology. And then we have the coordinating center team, which includes myself and the other program directors that I mentioned earlier, as well as the steering committee, and a lot of help from design experts, statisticians, pharmacists, and a lot of other experts to help provide support to everybody else, including the practices. So how does this whole thing work? Basically, MCT2D enrolls physician organizations in Michigan, which then in turn can notify their practices and enroll those practices. Excuse me. MCT2D then has the practices complete a change readiness assessment. And we work with the physician organizations and the practice clinical champions to educate on the quality initiatives and update you on all the resources available from MCT2D. The overall work is guided by a steering committee, which is comprised of people from the collaborative, so participating sites, as well as patients on the patient advisory board. And the coordinating center provides support and guidance, which I'll go into a little bit more detail, but this includes educational materials, help of implementation guidelines. We provide data reporting, so you know how well you're doing, and potential opportunity lists to identify areas you can do better. For example, patients that are not meeting certain metrics. And we also have regional meetings to discuss how we're doing and to learn from each other. So the specific goals of the nephrology component of MCT2D are basically 2 main goals. One is, and I'll go over each of these in more detail, but one is prescribing guideline concordant medications in patients with diabetes and chronic kidney disease. And the other is to increase urine albumin testing. So the specific medications we're focused on are the SGLT2 inhibitors and the incretin mimetics, which is kind of the newer umbrella name that is being used now for GLP-1 receptor antagonists and GIPs. As you know, these are 2 newer classes of medicines originally developed for diabetes to help with hyperglycemia, but what they've really now been shown is to have significant benefit in reducing both cardiovascular and adverse renal outcomes. And the incretin mimetics in particular also help to support significant weight loss. And they have also been shown to have mortality benefits overall as well. This is just a quick slide that shows all the a lot of the studies that have been done with some of the newer classes of medicines used for diabetes over the last 10 plus years. And you can see that there's been a huge proliferation in the for the SGLT2 inhibitor studies, as well as the GLP-1s or incretin mimetics. And this is just an example of one study. This is the Canvas study looking at canagliflozin in diabetic kidney disease. And basically, what they found was that there was a very significant reduction in the risk for the renal specific outcome with a hazard ratio of 0.66, which is basically a 34% reduction in these very important kidney outcomes over time. So very significant benefits seen from these medicines, and I'm sure your nephrologists were increasingly aware of the benefits of these medicines and trying to utilize these in our patients.
Yes, yeah.
And so with the SGLT2s and incretin mimetics, the indications, there's a variety of different indications. It's the majority of our patients, frankly. They have CKD indications, diabetic kidney disease with albuminuria, which is a high risk for progression. They are indicated even just for high cardiovascular risk in patients with diabetes. Certainly, they've been shown to have benefit in heart failure with or without diabetes, and especially the incretin mimetics for patients with obesity have shown to have significant benefit there as well. And so one of the things that we as the coordinating center do for the participating practices is we have data on your patients, which we'll talk about in a sec, and we can provide opportunity lists to outreach to patients who may be who may qualify for these meds that aren't already on them. So this shows some of the progress we've made in the first 3 years of the MCT2D program, where we started around 2020, and you can see that the rates of SGLT2 in yellow and the GLPs in blue have steadily gone up, and we hope to continue to make significant progress on this area, but it's been encouraging so far. The next major metric that we focus on, as I mentioned earlier, is albuminuria testing. And again, CKD is one of these classic iceberg conditions where in the past we really focused on the worst complications at the end of end-stage kidney disease. But now we recognize that, excuse me, earlier stages are where we can probably do our most benefit. And really this needs to involve earlier screening as well as intervention. And one of the key screening factors in the early stages is albuminuria. So again, preaching to the choir, I'm sure, albuminuria is obviously a very significant risk factor in terms of prognosticating for patients with chronic kidney disease, and even patients with relatively mild chronic kidney disease by GFR can be very high risk for progression to kidney failure if they have significant albuminuria. So it is something that we are trying to increase awareness around, both in the nephrology and the primary care groups, so that people are testing more regularly for albuminuria, identifying patients at significantly higher risk because of albuminuria for the various complications, which include kidney disease progression, but also cardiovascular disease and all-cause mortality. And then in those patients, especially prescribing appropriate therapies such as SGLT2 inhibitors. So next, we'll talk about data and participation in MCT2D. So in some of the traditional CQIs, like the hospital-based ones I mentioned earlier, such as the bariatric surgery or orthopedics, basically data was abstracted manually. So in other words, the programs would pay for a data person to collect the data from the hospital. And this is fine when you're dealing with, maybe a couple hundred or a few thousand surgeries spread out across Michigan. But obviously, when you look at something like diabetes with 1 million+ patients, it's a totally different level of data. And so when we set out on this with MCT2D, we knew we were going to have to do something different than the traditional manual data abstraction. And so what we have been working on is to develop a new data stream. Okay, so the data comes from MyHIN, or the Michigan Health Information Network. It is processed by a group called the Michigan Data Collaborative, and they are working with us to build a statewide, basically data platform, data and informatics platform that will include patients from all providers, and all participating providers, but also all payers. We are not quite there yet. Right now, the Data Hub includes data from Blue Cross and Blue Cross Blue Shield of Michigan and Blue Cross Network. We have claims and clinical data. Eventually, what we're continue to work towards and making progress on, we will want to include all payer clinical data, so all patients, and then additional labs to what we have now, and more claims data, and important things that we know are relevant to outcomes, such as social determinants of health. So we're working on all of those things. The important thing to focus on here is that as a provider, we will not be asking you to go in and manually collect any data or anything like that, because we know that's not an efficient use of your time, and that's never been our plan in terms of the data. We will work with physician organizations to make sure that the streams of data are turned on, that the data is flowing into MyHIN, so that we can then get it and collate it and everything, but it will not involve manual data abstraction. These are some of the data elements that we have. We have some of the medications, obviously, since that's a big part of what we're doing, not both the SGLT2s and the incretin mimetics, but also other medicines, because CGM, for example, is an important part of the primary care metrics for MCT2D. We have a variety of labs, some anthropometrics, and then a variety of other diagnostic codes, comorbidities, and such. And how do we track the progress in this program? So we, again, get the information through medical claims and clinical data from the participating practices. We use this to create dashboards for each practice, as well as for POs and for the overall collaborative. And then you can look and see how you're doing compared to the collaborative as a whole, others in the PO, and obviously your own practice, where the opportunities might be. So the goal of this is to measuring this information is to help provider awareness as to how they're doing, and provide targets for improvement, and hopefully help everybody deliver better overall care to patients. And all of the data is handled with the appropriate privacy regulations and requirements. So how do you use the data? We will share the data at the meetings and comparative, but blinded, so you'll know which is your data, but we don't unblind everybody for all the practices. We try to identify areas for improvement. We try to help with improvement within each practice, and share ideas. And the best part is you get rewarded for this, for participating in this, and hopefully achieving improved outcomes for your patients. So this is a snapshot of the evolving patient dashboard, what this would look like if you're a part of this program. And so you can see there's a variety of different things we can look at, some of which are being developed, but the summary measures, I think we have a a screenshot here. Summary measures would tell you how you were doing overall on various metrics. And this is a screenshot of some more specific measures, such as CGM prescribing. That's not part of what we're doing in the nephrology component per se, but you can look at this information. And if and when you're part of this collaborative, as you go forward, one of the things that we would do as part of the onboarding would be to obviously get you access to the dashboard and show you how to use this. These are just screenshots, so I can't show you, how to manipulate it. This is another example, though, on a patient level, what the dashboard can look like, where you can go into a specific patient. You can see some helpful data in terms of trends. recent things. And you can see what medicines they're on that are relevant to the collaborative and specifically to diabetes, and if they're on certain medicines, if they've been, when they were last prescribed and such. And again, one of the cool things of this dashboard is you can go in and you can sort. So you can say, I want to look at all my patients with a certain, within a certain age range, certain GFR range, and all of the ones that are or are not on SGLT2 inhibitors. And you can see which ones those are, and you can potentially flag them that way and say, okay, this is an opportunity for me to make sure I talk to these patients about SGLT2 inhibitors the next time they come in, or even outreach to them. Okay, so specifically talking about participation in MCT2D, there are 5 different types of requirements: administrative, attendance, data, engagement, and quality. I'm going to go over each of these. Administrative requirements include identifying a practice clinical champion who's going to be the champion and disseminate the information relative to this and champion quality improvement within the practice. We also need a practice liaison who can work with the physician organization about any data quality issues or completeness. And again, that's not manual data, that's just the flow of data. And then responding to inquiries and requests from your physician organization or us as the coordinating center, and just paperwork, sign and return required documents, such as the participation agreement. Attendance there are 2 main types of meetings two main meetings we have each year. The first is a spring regional meeting. We have divided the state into 7 different meetings. I'm actually going to go to the next slide. So we have regional meetings typically in the spring, April, May timeframe. There's, I believe, 7 different regions across the state. And so you would be assigned to a close region. So you wouldn't have to travel very far for these meetings, which are usually in person. They're in the evening. Dinner is provided. It's usually a pretty good dinner, actually. We have a lot of discussions where we can update providers, the practice champions, on latest literature that maybe we should know about, coming up about new trends in diabetes care or things like that, and also look at the overall trends and how we're doing as a collaborative. And there's a real focus on sharing with each other, working together. And because these meetings involve both the primary care and the specialists, nephrology and endocrinology, it's a really nice opportunity to talk with some of the people referring to you and share some ideas and also give feedback as well. From a more specific nephrology, we have 1 time a year, a meeting in the fall, usually around November. So far, we've been doing this virtually, but next year we are likely to make this an in-person meeting, which means it might be a little bit further travel, although we'll try to make this as central a location as possible. So attendance is required, and very similar to what we do at the regional meetings, except that it's focused on the nephrology components mainly. And again, this is very much a collaborative, so it's not just us sharing data and talking to the members of the collaborative. It's also very much hearing from members of the collaborative and getting feedback. In terms of data, we just ask that the required data elements are shared with MyHIN, and that is where the physician organizations can really help and make sure that the appropriate data streams are turned on and that the data is moving along to MyHIN so that we can appropriately access it and work with that data to support the overall CQI efforts. We ask, obviously, for good engagement to participate in the training programs as needed for different things coming up, and then to distribute patient education materials and toolkits as needed. For quality, obviously this is the biggest focus, and we're trying to ensure that people are actually interested in improving and working with us to implement the best practices. This is not something where we just tell you to go and do this. This is very much us as a coordinating center and other practices within the collaborative working together to share best practices and give each other ideas on ways to improve in an efficient way. And however we can support that as the coordinating center, we want to do that. I'll give some examples of that coming up. So what are the incentives and benefits for the nephrologist to participating in this? There's a couple different categories. I'll go into each of these. The first is the value-based reimbursement. So you do get paid more to participate in this and to successfully improve as part of this program. And then you have access to tools and resources, and overall the collaboration and the community of the CQI is a very supportive community. So I always really enjoy the regional and fall collaborative wide meeting where we really get to know colleagues better from across the state. So with the value-based reimbursement, basically Blue Cross Blue Shield supports these quality programs, as I mentioned earlier. And by participating in this, practitioners have the opportunity to earn additional payments through what is called value-based reimbursement, or VBR. Basically, the VBR schedule is means getting a fees greater than 100% of the standard fee schedule. And for participating in MCT2D, you can get a 5% increase over the standard fee schedule for being part of this program. And I'll talk about what the specific requirements are, but in the first year, they're largely participation based, okay? So it's not right off the bat having to try to achieve any specific very high clinical goals or anything like that. It's really about integrating into the CQI, especially in the first year. And one of the questions I've been frequently asked in the past is there a risk basically involved here? There is no penalty. So again, you don't, this is not like the QIP program for dialysis where 2% is withheld and you get the 2% back if you meet the goals. This is 5% above what you would otherwise be getting or not. So you won't get any less than you would have already gotten by participating. There is no risk here. It is the opportunity to earn 5% more. And also to be clear, the 5% more is on all of the Blue Cross Blue Shield payments, not just for the specific patients that you might have made a change on in this program. So it's an across the board payment. So what are those specific VBR requirements? These are the ones. So I'm just going to go through them very quickly so you have an idea of exactly what you would be looking at. Number one is to identify a clinical champion and practice liaison, as I mentioned. So all you have to do is tell us who that would be. Number two is to complete the practice change readiness assessment, which is basically a survey. Again, you have plenty of time to do that. It's a very straightforward survey that takes less than 10 minutes. Participating in an onboarding call with the nephrology program directors, which would be myself. We would already started that process with the overview here, but we go into a little bit more detail and more interactive to answer more questions on that. And again, plenty of time to do that. I mentioned the attendance requirements, so we'd ask you to attend the spring regional meeting. And if the clinical champion can't make it, you can designate somebody else, but we do ask for a representative from the practice. And then to attend the fall clinical champion meeting, so those 2 meetings for attendance. To submit a brief form identifying a barrier in the practice. So just kind of like a thought exercise to go through. Again, very, very simple survey type questions and does not take more than 10-15 minutes to complete. And then when asked, we would ask you to submit updates on the progress in addressing the quality areas that you are focusing on. And then potentially at some of the meetings to present on how you're doing. And you can see there are point systems here. And so it's although I think it's pretty easy to do all of these and get a full 100% of points. If you're a little bit late on some of these, they've built in a little bit of room for error, so where you can still get the VBR even if you miss the deadline for one thing, because you can still get points and you can still qualify for the VBR. Okay, so the other thing you can get out of this, other than the payment, is access to the tools and resources. We, as the coordinating center, I feel really lucky. We get to work with a team of people that are really highly engaged and interested in developing educational materials for both providers and patients. These are some examples. This is a handout. This is, I think this is actually the older version of it. It's even been updated now, of a one-pager that's the benefits of SGLT2 inhibitors. So, I know when I started prescribing these, I had to remember what all the side effects were and try to use a cheat sheet. And this is what we developed as a cheat sheet that you can use, but also that you can then just hand to the patients, and it gives them a lot of information as to what kinds of things to expect after starting an SGLT2, when to call back, what to do, things like that. There's also information about copay savings or patient assistance programs in here as well. So this is a nice handy sheet, and we have copies for you to take at our regional meetings, or you can just simply download this and print these out at your practice. These are available. Actually, they're available publicly. They're not exclusive, so whether you sign up or not, you can go here and look at these resources. We also have a book that's basically just a PDF with several pages that's specifically for nephrologists, with some of these newer medicines and some dosing information, some prescription information. I think I have, an example of that. This is a chart that we try to update quite regularly that shows some of the major insurances in Michigan and what the coverage is, or what the coverage requirements are for, in this case, some of the GLPs. We have this same table for SGLT2 inhibitors as well. So it's nice. We have these posted in our clinics at the University of Michigan, so we can sometimes take a quick look and just say, oh, okay, this person has priority health. If I'm going to do a GLP-1, I can do Trulicity, but not Rybelsus, as an example. So just saves some time, saves the call later when the patient calls back and says, this wasn't covered and we need to go there. And again, we try to keep all of this updated to make this as useful as possible for providers at the, in the clinic. Another benefit, again, is the collaboration. So both at our regional meetings and the collaborative-wide clinical champion meeting at the fall, we are trying to ensure we're having touch points, every month or every other month. So we'll do learning community meetings that you can sign up for, where we'll talk about emerging things. So again, one of the things we really focus on is how we can be value added as a collaborative to our participating practitioners and practices. And so we also want to hear back from you as to what would be really helpful. And we have, again, resources to help develop those things, whether it's more handouts, different types of handouts, lectures, or things on newer things coming out. For example, in the fall, we're going to be, at our fall meeting, we're going to be talking more about GLP prescription, especially since the FLOW trial came out a few months ago that now shows renal benefits from the GLP-1s. So that's probably something we should be prescribing more as nephrologists as well now. But a lot of us don't feel that comfortable with it. So we're going to be discussing that. So that's the kind of the overall summary, and you can, again, I would encourage you to go to the website where you can see some of the resources. There's also a nephrology specific subsection that you can read more about what we talked about today. But I'm going to stop there, and I'd be happy to answer any questions you might have.
How many times the nephrologists are following about the metrics of like what you said, the diabetic retinopathy or the CGM, and like you said already.
Yeah, those aren't actually metrics for the nephrologist. Those are the CGMs and things like that. We're not prescribing those. I don't prescribe those as a nephrologist.
Exactly.
Yeah, no, those are not part of it. The two that we have focused on to this point are the albuminuria testing and the SGLT2 or GLP-1s.
And like you said, usually in our practice, we do definitely follow the proteinuria or albuminuria. And I do encourage most of like my patients, eligible patients for SGL2, but I'm not comfortable with the GLP-1's prescription, which I haven't done. I have patients, mutual patients with endocrinology who they started, but I'm not comfortable, especially with the big shortage of these medications, prior authorizations. I feel like as a nephrologist, I have enough on my plate to take care about their blood pressures and their diuretics. And I definitely follow the proteinuria and ACE inhibitors and ARBs and SGL2, but I wasn't comfortable and I'm not practicing yet the GLP-1 inhibitors. Like I haven't started that. That's feel like it's a whole big can to open to our practice to do it. And do you prescribe the GLP-1s for your patients?
I do. I have started it, but you're not alone, and I feel far more comfortable with myself with SGLT2s than I do with GLP-1s. So I'm completely with you. What I would say is I would answer that in several ways. One is nobody is forcing you to prescribe GLP-1s. Like the metric is SGLT2s or GLP-1s, so it doesn't have to be that. Number two, if you have a good partnership with the endocrinologist or primary care and they're prescribing the GLP-1s, you still get credit for that. So it doesn't matter whether you're prescribing it or not. It's simply whether your patients are on these medicines or not. So whoever's prescribing it, whether cardiology is prescribing it, you still get credit. So I didn't specifically mention that, but that's an important point. So because what we care about is not who's getting the credit, it's that the patient is getting the proper medicines, right?
Right, exactly.
Yeah, so you get credit no matter who's prescribing it. And number three, I would say the other way I'd answer that is that we hope that we will empower you to feel more comfortable with these medicines. It's still up to you whether you want to start prescribing these medicines. One reason I've started to prescribe them more is because of the newer studies that suggest renal benefit. So, you know, I think of them now that just like, I don't know how you felt, but when first the SGLT2 inhibitors came out, I was not prescribing them either because I thought, well, they're really for diabetes. But I think we now see that they're really kidney medicines, right? And so I think we're seeing more evidence that that is also going to be true with the GLPs. The flow study is something I'm going to present it just was published in June, I think. That's with semaglutide, and where they showed that there was a slowing of progression of kidney disease in patients with diabetes. So I think we're starting to see the same thing with GLPs as we did with the SGLT2. So, you know, it'll probably take us all some time, but it took me a little bit of time to feel very comfortable with SGLT2s like I do now. And so if we can help be part of that journey for GLPs, then I think that's where we're coming into. But even if it takes a long time, that's not going to be like a rate limiting step for this. I really don't think so. That we're not going to, that's not the goal. It's not to make this like so restrictive or anything like that.
Okay.
Does that make sense?
Right. Yeah, that does make sense. And I also like the difficulty to get these medications, GLP-1s, which makes, because some of the patients asks me to help them to give the prescription, but with all the prior authorizations, difficulty because most of the pharmacies, like they don't have, and it's a lot more to take. And most of these patients, like you said, they have endocrinologists, they have PCPs. And so I haven't started putting my finger into the GLP-1s, but yes, I am 100%
Yeah,
comfortable with SGLT inhibitors and proteinuria control, ACE and ARBs. And yes, I do counsel them about the diabetes control, but I haven't started looking into GLP-1's prescription
yeah.
myself. Yeah.
We have a lot of supportive educational material, exactly what you described, all the drug shortages. Those are frequent conversations we're having at our meetings with the providers, not our internal meetings. I'm talking about the regional meetings and the collaborative wide meetings. And the overall director of MCT2D, Lauren Oshman, and one of the co-directors, Heidi Dietz, who's a pharmacist. They've done a lot of advocacy, working with national organizations to, ensure they're hearing about all the shortages, which I think they are. They're probably well aware of, and trying to work on it. It's not a quick fix, unfortunately, because already these shortages have been an issue for, a couple of years. But they have some nice informational sheets which you can look up at mct2d.org that give advice to patients as to what to do if you're at your last couple of injections, but the next, now you heard from pharmacy that they don't have available. We have conversion things. Some people switch from one to another to maintain it. So things like that, I agree. I'm not that comfortable with it either because I don't do it that much.
Right.
But the point is, we're not telling you to do it on your own, right? Like
Okay.
we are providing support if you want to do that.
Right. Okay.
And but we're not trying. Nobody's here to force the issue of that either. But
Okay.
I think it's going to be part of what we're doing in the future because again, I see so many of these things now as really kidney medicines as well.
Right, right. Like you said, I agree 100% that for SGL2s, I wasn't comfortable a few years ago,
Yep.
but now I am as comfortable as with ACE and ARBs to put them on for the diabetes patients. So I agree that that's probably, I did read that article in NEJM about the semi-glutamate, which I read it, but like as I said, I haven't started practicing that
Yeah.
yet.
Yeah.
With all the shortage and the paperwork involved to get that. And
Yeah.
with the clinical champion being a nephrologist, how much time commitment with all the meetings you did, say how much time? That was more worrisome to me because you know that as a practicing physician with all the clinical work and finishing the notes and everything, we are
Oh
already
yeah.
stretched. We already stretched thin. I have to literally throw my last patient out the door to attend this meeting, honestly. So,
I'm sorry.
no, I'm just kidding. Like that's like a thin, in a matter of 5 minutes, I had to rush to
Yeah.
the computer.
Yeah.
So how much
Well,
time commitment with all these meetings you kind of mentioned through
so
the
we're talking, I mean, like again, the attendance requirement is we're talking about 2 meetings a year. The first meeting is the regional meeting in the spring. There's seven different regions. You would be belonging in one region. You would only attend one meeting. It's a 2-hour meeting in the evening after hours. So hopefully after you've tucked away the patients and
right.
done your documentation. We serve dinner, so it's and there's really not much. There's really no preparation for the most part. I mean, sometimes we'll ask people to share stories or share their work. So there could be something like that, but most of the time, especially those regional meetings, it's an opportunity for us to get together, brainstorm a little bit, us to share updates from the coordinating center as to how things are going, but also to meet other nephrologists in the region, to meet primary care physicians in the region and endocrinologists. And again, so we're talking about 2 hours. And then in the fall, also similar meeting that would be just for the nephrologists, also usually about 2 hours. Now, we like I alluded to, in the future, we may want to do that in person just because it's so much more high yield in person when we can all, get together and talk and everything. But we definitely recognize the time commitment. If we do have it in person, depending on where it is, we would pay for people's hotel to stay overnight, even have the meeting in the morning, and then have people be able to go home after, usually on a Saturday morning or something like that. Those are details that we work out, and we try to be as accommodating as possible for everybody. But those are the two meetings that are basically the required things. The time commitment beyond that is really what you make of it, frankly. It's how much you want to get involved in terms of, working on projects in the office. And again, we're there to support. We've even offered to come out to practices and to help do practice assessment if you think it would be helpful to share ideas from other practices. Again, we provide handouts, all kinds of different things, educational materials. We will develop things. If there's something you wish you had in your practice and you don't, we can help develop that. We actually have designers on the team that's their job. I do not know how to do any of the art stuff. None of these slides did I even make. I mean, we have these designers that do all this great work to help us, and they're real professionals at that. So those are all the resources that we try to support the practices and the clinical champions with.